Welcome to Editor's Choice, the podcast at EuroIntervention, where we highlight the latest science and research in interventional cardiology. I'm your host, Aaysha Cader, and through conversations with the authors, we explore study design, key findings, and their relevance in contemporary practice. I'm very pleased to be joined today by Dr. Juan Miguel Ruiz-Nodar from the Dr. Balmes General University Hospital in Alicante, Spain. And we will be discussing his paper titled Glucocorticoids to Reduce Permanent Pacemaker Implantation After TAVI, the GLUCO-TAVI randomized trial published in this issue of EuroIntervention. Welcome, Dr. Ruiz-Nodar.
Thank you very much, Dr. Cader. It's a pleasure for mine to be here. Thank you very much.
Thank you for discussing this on the podcast. So, cardiac conduction disturbances are the most common post-TAVI complication. Tell us about the background and rationale to this pilot GLUCO-TAVI study that you conducted.
Yes, over the past decade, TAVI has grown exponentially, mainly due to the aging population and the expansions of indication, now including intermediate and low-risk patients. But despite this progress, we still don't have a clear strategy to prevent one of its most common complications, conduction disturbances requiring permanent pacemaker implantation. This affects around 13 to 17% of patients. The mechanism is clearly multifactorial, but many of these disturbances seem to be transient rather than purely mechanical, suggesting that inflammation may play an important role. In fact, up to 50% of TAVI patients develop a systemic inflammatory response, which can lead to local edema and fibrosis and potentially affect the conduction system. So we thought, could an anti-inflammatory strategy like glucocorticoids reduce the need for pacemakers after TAVI?
All right. So, based on this sort of hypothesis, you designed a prospective randomized open-label blinded endpoint or probe design pilot study, which was registered as a phase 4 trial. Tell us about the methodology and the trial design, and also what sort of patients did you recruit?
Yes, we conducted a prospective randomized open-label blinded endpoint study. This was a single-center pilot study, including 100 patients randomized in a 1-to-1 ratio to standard care or glucocorticoid therapy. Inclusion criteria were broad: patients with severe symptomatic aortic stenosis eligible for TAVI according to the European guidelines. And exclusion criteria were mainly prior pacemaker, contraindication to steroids, chronic steroid use, or non-femoral approach. Operators were aware of treatment allocation, but endpoint assessment and data analysis were blinded.
And could you explain for us the rationale for the selection of the steroid regimen and the dose administered during the study?
Yes, it's very important. The intervention group received 7 milligrams per kilo of intravenous methylprednisolone 1 hour before the procedure, followed by oral prednisone 15 milligrams every 12 hours for 5 days. Tapering was not required. We chose a higher dose than previous studies, as a lower dose had shown no benefit. This strategy is consistent with current European guidelines for the treatment of inflammatory cardiac conditions, such as lymphocytic cell myocarditis.
Okay, and based on this inflammation hypothesis, you set out some efficacy and safety outcomes. Could you elaborate for us which endpoints you studied?
Yes, the primary endpoint was pacemaker implantation at 1 month. The decision was made by a team including the attending physician and an electrophysiologist. The interventional cardiologists who performed the TAVI didn't participate in the decision. Secondary efficacy outcomes included pacemaker at 1 year, new onset left Van der Branch block and its resolution. We also studied safety endpoints, including mortality, procedural complications, and steroid-related adverse events.
Okay, thank you for that. And this was, of course, a pilot trial for effect size estimation rather than hypothesis testing. So, what design features from a statistical standpoint are noteworthy in this trial?
That's a great question. This was a pilot trial, a pilot study. So the goal was to estimate effect size rather than prove a hypothesis. The sample size was relatively small, 100 patients, and chosen mainly for feasibility, not to detect statistical significant differences. We focused on relative risks rather than p-values, and we used a proof design to reduce bias. And statistically, we applied Poisson regression to estimate relative risk, which is more appropriate than odds ratio in this context. We also avoided subgroup analysis to prevent overinterpretation of the data.
Thank you for explaining the background and statistical components of this trial. Could you now tell us what were the most important findings in terms of results?
Yes, baseline characteristics were well balanced in the two groups with a mean age of 81.5 years. We observed a reduction in pacemaker implantation at 1 month from 16% in the control group to 8% in the glucocorticoid group, corresponding to a 50% relative risk reduction. There was also a trend towards a lower combined endpoint of pacemaker and persistent left VVV.
Okay, you mentioned the 50% relative risk reduction for those that had steroids versus standard of care in terms of 1 month ppm, albeit not reaching statistical significance. So, could you explain how should readers interpret these results in the light of this being a pilot trial?
Yes, although the reduction in pacemaker in the intervention group didn't reach statistical significance due to the limited sample size inherent in pilot studies, the observed 50% relative risk reduction may still be clinically relevant. An interesting fact is that the number of patients that needed to be treated to avoid a pacemaker was 12.5.
Okay, and you also looked at baseline and procedural characteristics, including valve type, between the steroid and standard of care arms in this study to possibly look for any confounders. What did you find?
Yes, we analyzed baseline and procedural characteristics between the two groups to ensure that the results were not influenced by confounding factors, such as established risk factors for post-TAVI cardiac conduction disturbances. For example, the prevalence of cell-expandable valve, baseline right BBB, and deeper implantations was numerically higher in the control group, but none reaches statistical significance. On the other hand, baseline aortic valve calcification was significantly greater in the intervention group, biasing the results against this group. Therefore, residual confounding by these factors cannot be excluded.
Absolutely. And also, left bundle branch block and QRS duration and their resolution are two other important parameters post-TAVI. What did your study find between groups in relation to these two endpoints?
Yes, in relation to the secondary endpoints, we must say that new onset left BBB is a clinical relevant complication. Therefore, the strategies aimed at reducing new onset left BBB have significant prognostic implications. New onset left BBB occurred in 34% of the control group and 38% of the intervention group, aligning with the upper range of reported incidences in the literature. However, the glucocorticoid group showed a significant reduction in QRS duration at 1 month, suggesting possible reversibility of conduction disturbances.
Also supporting the inflammation hypothesis you set out in the rationale. Another important aspect of this is the demonstration of safety of this particular steroid regimen and dose. What are your conclusions based on this pilot?
Yes, absolutely. Safety is key in a pilot study, and overall, the treatment appears safe. Mortality and vascular complications were similar between groups. We observed one episode of hyperglycemia in the intervention group and 3 cases of heart failure descompensation, 1 in the control group and 2 in the intervention group. Importantly, we did not observe an excess of bleeding or major complications despite previous concerns in a recent meta-analysis.
This is an important pilot study. There isn't a lot of background in terms of the literature, but in the limited literature, how does the results of your pilot study compare with previous literature in this space?
Yes, there have been a couple of studies looking at glucocorticoids in TAVI, but the results are quite mixed. Aaysha and colleagues did a retrospective study with 167 patients and found that none of the patients who received glucocorticoids needed a pacemaker, compared with about 30% in the untreated group. On the other hand, Habakuk and colleagues didn't find any reduction in conduction disturbances or pacemaker implantation. One of the key differences between these studies seems to be how long patients were exposed to glucocorticoids. In my opinion, differences in duration, dose, and type of steroids probably play an important role. Short treatments may be insufficient, while longer ones increase the risk of side effects.
These are all very interesting results and discussions around this pilot study. However, could you tell us what limitations should readers be aware of when interpreting these results?
I completely agree. As a pilot trial, we didn't formally calculate the sample size. Moreover, the open label design may have introduced bias. Although operators were aware of treatment allocation, which could have influenced intra-procedural decisions such as implantation depth. All key endpoints were adjudicated by an independent electrophysiologist unaware of the patient's treatment group affiliation. And finally, we still don't know the optimal steroid regimen.
Thank you, Dr. Ruiz-Nodar. These results have generated a hypothesis upon which future trials can be designed, as you suggested in the manuscript. So what would you say are the key design aspects in a future trial examining this inflammation hypothesis in TAVI patients to prevent cardiac conduction disturbances?
Yes, these hypothesis-generating findings suggest that a short course of glucocorticoids represents a potential strategy to reduce post-TAVI conduction disturbances. The next step must be a larger, adequately powered, multi-center randomized trial to confirm these findings and to better define the optimal dosing and duration of glucocorticoid therapy. In fact, we are already working on this with an estimated sample size of around 600 patients. It's challenging, but important to provide a definitive answer, especially now that TAVI is being used more and more in lower risk patients. Finding ways to reduce pacemaker implantation is becoming increasingly relevant. And if these results are confirmed, this could be a simple and relatively low-cost strategy to reduce one of the most common complications of TAVI.
Perfect. And we look forward to the results of that randomized trial in the future. Dr. Ruiz-Nodar, thank you very much for coming on this podcast and explaining the results of your pilot trial.
Thank you very much, Dr. Cader. It has been my pleasure.
Thank you for listening to Editor's Choice.
To read the full article discussed in this episode, visit EuroIntervention.org. And if you've enjoyed this podcast, please subscribe to Editor's Choice for more conversations behind the science published in EuroIntervention.